From the American Academy of Pediatrics.
Toxic environmental hazards are a major cause of disease and death among children.
New policy from the AAP looks at environmental issues in global pediatric health.
We need to fundamentally rewrite chemical law and policy in this country to prioritize children's health. Otherwise, we continue to poison children.
Plus, research on pediatric subspecialty fellows questions when they're ready for unsupervised practice.
If people really feel strongly that a reduction in the duration of fellowship is needed to get more people into our fields or just for better patient care, to get more people into becoming faculty and practicing clinicians, then they have to be ready for some unintended consequences, and they have to be ready for fellowship training to change.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a discussion about environmental issues in global pediatric health.
Joanna, here's a not random question. What can you tell me about the air and water quality there in Philadelphia today?
We have at times struggled with water quality. There was a chemical leak that affected our water supply in the city in 2023, but it was well contained, and being in the city, it always makes me consider air quality, but I feel like the 2023 fires in Canada got me checking air quality more than any city-side event. Why do you ask?
Well, not only do you have 3 young children who are especially susceptible to changes in air and water quality, but you also work in a NICU, and preterm births are more common when the air quality is worse.
You are right, and these are just a few examples of environmental hazards that can occur. There are so many more, especially when we look beyond the United States. It's almost too big a problem to grasp.
Fortunately, we have a guest with us who has a lot of practice addressing this problem. Dr. Philip Landrigan is a professor at Boston College, where he is director of the Program for Global Public Health and the Common Good and director of the Global Observatory on Planetary Health. He's also an author on a new technical report and policy statement from the AAP Council on Environmental Health and Climate Change, Environmental Issues in Global Pediatric Health. Dr. Landrigan, welcome.
David, it's good to be here. Thank you.
Philip, can you put this problem in perspective globally? How many children have health issues from environmental causes as compared to, say, infectious diseases?
Well, toxic environmental exposures are a big problem in every country around the world. And a couple of years ago, I co-led the Lancet Commission on Pollution and Health. We estimated that pollution in all its forms, air, water, chemical, soil pollution, kills about 9 million people around the world every year. And that's probably a conservative estimate. That's 3 times more than AIDS, malaria, and TB put together. Not surprisingly, many of those victims of environmental pollution are children.
We've talked about health justice on this podcast in the past, but our listeners might find the term environmental justice new. Can you define environmental justice and what it means in terms of children's toxic exposures?
Yes, of course. So environmental injustice is the disproportionate exposure of some populations to toxic environmental hazards. Think, for example, of the people who live and work in Cancer Alley along the lower Mississippi. Those are mostly historically Black communities, very low income, and they live in an area where chemical and plastic factories are lined up side by side, cheek by jowl, for something like 60 miles along the lower Mississippi, with the fumes spilling out into the nearby communities. And those communities suffer disproportionately high rates of premature birth, low birth weight, asthma, cancer, and neurological diseases.
And how does climate change relate to these types of toxic exposures?
So climate change aggravates the problem of pollution because as the world gets warmer, we need to burn more fossil fuels to cool our homes and buildings, and that increased combustion of fossil fuels results in increased release to the atmosphere of air pollutants.
Now, I know there are far too many toxins to review all of them here, but can you give us examples of some that you think should be on most pediatricians' radars?
Well, Firstly, the classics like lead. Lead is still a major problem in the United States. We've reduced children's lead exposure by 95% since the 1970s by getting lead out of gasoline, getting it out of new paint. But unfortunately, there are still many thousands of housing units around the U.S. that have lead paint, and there are still homes in the United States that are at risk of exposure to lead in drinking water because they have lead service lines bringing the water into the house. Then, of course, air pollution, which is everywhere in the country, but most especially concentrated in city centers and along major roadways and in highly industrialized zones. Pesticides are always a problem. Pesticides are a problem for children growing up on farms in the country, and there have been multiple reports showing that children who are exposed in early life to mixtures of pesticides have increased risk of childhood leukemia. And pesticides are a problem also for kids in inner cities where lots of pesticides are applied to control cockroaches and other pests in urban apartments and often right in the areas where children play. And then yet another category of chemicals where children are at risk of exposure are the multiple different toxic chemicals in plastics. These include phthalates and bisphenols and brominated flame retardants. And those chemicals come out of plastics. They come out of a rubber ducky. They come out of a baby bottle. They come out of another plastic toy that a child plays with and puts in their mouth and chews upon.
And thinking back to your career in this field and everything you've seen, is there a particular experience that sticks with you or moves you to this day?
Well, I think something that keeps me going for more than 50 years of looking at the impact of environmental toxins on children's health is it really bothers me when I see children being bullied by corporations that spew toxic chemicals out into the environment or put toxic chemicals into products, knowing full well that children are going to be exposed to those chemicals and are going to suffer disease and possibly even premature death as the result of those exposures. That I guess I was brought up with a strong sense of social justice and a moral code that you don't beat up on people who are smaller than yourself, and that keeps me going in this business.
So how can we as practicing clinicians begin to integrate thinking about these issues and addressing them in our practices?
Well, I think a very straightforward way that pediatricians can assess children's exposure to toxic chemicals in the environment is to ask just a very few screening questions when they meet each new patient or when they see a patient whom they haven't seen for a long time or when they see a patient whose circumstances have changed. So ask, for example, about whether they live in an old house with peeling paint. That covers lead. Ask about pesticide use in the home, on the lawn, on the garden, or if they're in a farm area, in the farm near the house. Ask about their use of plastics and chemical products in the home. And if those screening questions are negative, then it's only maybe 30 seconds out of a busy interview. I know that every practicing pediatrician is too busy, so you got to keep it short. But if any of those screening questions does elicit a positive answer, then you can take another minute or two and dig deeper and find out what's going on. And if you do uncover or do suspect that a child is exposed to an environmental toxicant, there's a very fine set of resources around the country to which practicing pediatricians can refer patients and their families. And those are the Pediatric Environmental Health Specialty Units, the PESUs, of which there are roughly a dozen scattered across the United States, one in each of the federal regions, supported by CDC, mostly based at children's hospitals. And these PESUs are staffed by pediatricians, nurses, environmental scientists. They're available to consult. They're available to see patients, and at least in some instances, they even will make house calls to assess environmental problems in the home environment. They're a great resource. It's analogous to a pediatrician referring a patient with seizures to the pediatric neurologist or a child with leukemia to the hematologist.
And you know, I have a friend who approached our congressperson recently about a PFAS issue here. And our member of Congress replied that environmental pollution is just too big a problem to solve. There's nothing that we can do about it. It would be too expensive to even try. How do you answer people who say there's nothing we can do?
I would disagree strongly with that issue, and let me give you two lines of argument to use against it. The first is that we have very successfully controlled multiple forms of pollution in this country over the past 75 years. So, for example, since President Nixon signed the Clean Air Act in 1970, we have reduced air pollutant emissions in the United States of America by 77%. That's a huge increase, an enormous increase in air quality, which has saved tens of thousands of lives. It's prevented premature births and low birth weights in infants. It's prevented asthma. And in adults, it's prevented heart disease and stroke and lung cancer. We've taken lead out of gasoline. That single action reduced blood lead levels in American children by 95%. We've cleaned up the drinking water. So we can do it if we put our minds to it. Furthermore, the second big line of argument is that every one of those advances in environmental public health has been highly cost effective. It actually ends up saving money because it keeps the population healthier, keeps kids out of the hospital, reduces healthcare costs, and because the kids who are tomorrow's adults are healthier and more intelligent and more robust because they've not grown up in polluted environments, they're more economically productive and they have higher projected lifetime earnings. And so, for example, in regard to air pollution, it's been calculated that every dollar invested in the control of air pollution since 1970 has yielded a $30 return on investment, a 30-to-1 return on investment. It's been calculated that the removal of lead from gasoline resulted first in reduction in children's blood lead levels, second in an average 5-point gain in the IQ of every child born since 1980 compared to kids of earlier generations. And because those children with higher IQs are smarter and more creative, they're more economically productive. And the economists who looked at this have calculated that the economic benefit in each annual birth cohort born in the United States since 1980 has been $200 billion over those children's lifetime. And since that's 40 plus years at this point, we're talking about an aggregate benefit to the American economy of more than $8 trillion. That's enormous. So I think these two lines of argument counter the false claim that cleaning up pollution will kill the economy, or that it's too expensive, or it can't be done, or it just costs too much money. Those tropes are simply not true.
I love talking about solutions with you. What would you like to see happen in terms of policy and education here in the United States now?
Well, I think the biggest single gap in our policy array right now concerns the chemicals that go into consumer products. Backing up a step, chemicals that are designed to be used as pharmaceuticals, to go into prescription drugs, are very carefully regulated. Ever since the terrible thalidomide tragedy in the 1950s and 1960s, pharmaceuticals have to be proven safe, they have to be proven effective. As we all know, they have to go through clinical trials, and they don't get on the market until they've crossed all those hurdles. And then even after they're on the market, there's post-market surveillance to make sure that no unanticipated problems come along. By contrast, pretty much all the rest of the chemicals that go into consumer products, for all practical purposes, are unregulated. Yes, there's legislation on the books. It's called the Toxic Substances Control Act of 1976. But unfortunately, it's been made toothless over the years, and only 5 chemicals have been taken off the market in the nearly 50 years that TSCA has been on the books. The EPA has been denied the power to enforce the law. The federal courts have further taken the power away from EPA. For example, it's still legal to use asbestos in the United States, which is hard for me to believe. About 60 other countries have completely banned this stuff, and it's a well-known carcinogen. So I think the biggest single legislative and policy need in this country is to fundamentally revamp chemical policy. A group of us had a big article in January in the New England Journal of Medicine called Manufactured Chemicals in Children's Health, and we made the case that chemical safety law in this country is broken. It presumes that chemicals are safe. They have to be proven harmful before they can take off the market. That's a process that can take decades. And we need to fundamentally rewrite chemical law and policy in this country to prioritize children's health. Otherwise, we continue to poison children.
So, Philip, at the moment that you're publishing this article, it would seem that the United States is dedicating fewer, not more, resources into environmental and global health. Do you have any hope that we can reverse that trend?
Well, we're in complex political times, and I don't expect that there will be a lot of enthusiasm for strengthening chemical regulation at the federal level for the next few years. But, not all power in the United States resides in Washington. And the states have a lot of power, a lot of latitude to reduce children's exposure to toxic chemicals. They can ban certain products. They can restrict sales of certain products. And if 3 or 4 big states, think, for example, New York, California, Massachusetts, Minnesota, maybe 1 or 2 others, decide that a certain pesticide like neonicotinoids or a certain chemical like asbestos is too harmful to allow on the market, they can ban that chemical in their state and disrupt national markets and force change. We've seen this happen before.
This has been such a wide-ranging and important discussion. Philip, can you leave our listeners with one takeaway before they read these documents for themselves?
Well, I think the single most important thing to remember here is that infants and children are much more vulnerable to chemicals and other toxic hazards in the environment than the rest of us. And so if we pass laws and regulations that protect our children, which is certainly the right thing to do, it will also protect everybody.
Well, Dr. Philip Landrigan, thank you for what you're doing to help protect children, and thank you for joining us today.
A pleasure. Thank you, David. Thank you, Joanna.
To read the technical report and policy statement, Environmental Issues in Global Pediatric Health, go to aap.org/podcast.
Coming up, we'll look at when pediatrics subspecialty fellows are ready for unsupervised work. There is always chatter in neonatology that the pediatric residency portion could be shorter to allow for more time in neonatology fellowship and the NICU itself.
As medicine in general gets more complex, I don't see how you shorten anything. The volume of information we have to absorb just keeps growing, not to mention the clinical experience needed to make that knowledge actionable.
At the same time, I know a lot of general pediatricians would like to subspecialize, but then they have to factor in the extra time in training, and sometimes financially it might not make sense. So it's no wonder some pediatric subspecialties have so few members when there's no extra pay for taking 2 or 3 more years to enter the workforce.
I think we need to talk about what changes we could make in pediatric training. Here to help is Dr. Sarah Pitts. She's the lead author on a new paper. Many pediatric subspecialty fellows are not ready to graduate from fellowship in 2 years.
She is also an associate professor of pediatrics at Harvard Medical School, where she specializes in adolescent and young adult medicine and is the program director for the Adolescent Medicine Fellowship at Boston Children's Hospital. Dr. Pitts, welcome to the show.
Thank you for having me. It's a pleasure to be here.
What Joanna didn't mention, Dr. Pitts, is that you are on the Education and Training Committee of the American Board of Pediatrics. And as someone on that committee, it must be top of mind for you that fewer trainees are entering pediatrics in general. Was that part of your motivation to write a paper looking at changes in training?
Yes, certainly. This is definitely a hot topic right now, and one that's being driven from all different levels, including trainees, ABP thinking about it, leaders of children's hospitals and other pediatric programs, professional societies, of course, thinking about duration of training and how to get more trainees into the field of pediatrics and pediatric subspecialties. So certainly was a driving force behind doing this study, which came out of the APPD SPIN, which stands for Association of Pediatric Program Directors, Subspecialty Pediatric Investigator Network. And this is a group of pediatric subspecialists who do medical education research, and this was one of the driving forces for this project, was to figure out what's happening in training, and if there are changes, how could they be done?
And speaking of changes, what is the evidence for making subspecialty training 2 years, not 3, as it is for many pediatric subspecialties?
I think adolescent medicine is kind of well set up to answer this question because we actually get specialists and trainees that come to us both from pediatrics, internal medicine, med peds, and family medicine. And for anyone who's board certified in adolescent medicine through family medicine or the internal medicine pathway, they can graduate in 2 years. And I've had many trainees coming from those paths. So I've graduated people in 2 years, feeling that they were competent and ready to go out into practice. But the requirements are different, and there isn't the scholarly expectation in the same way that is required for pediatrics. So I think that was the big question of, should something change? And this paper brought that up. The way things are currently set up for pediatric trainees going through fellowship, we're not set up to necessarily finish in 3 years with all the expectations that are there, both clinical and academic. But if they were to do 2, how might it have to look differently? And that's the big question that at the end of this paper, which is kind of just hanging out there and for people to think about. But I think there's a desire, there's an interest, there's a hope that maybe it would result in more people going into pediatric subspecialties. But that's also just a hope and not proof. I think in the end of the day, it would be yet to be determined if that was a make or break reason for people going into our subspecialties.
So anyone in medical training undergoes evaluations or assessments that help their mentors know if they're on track with their skills. What assessments did you use for this study?
So we use something called Entrustable Professional Activities, or EPAs. And I actually heard recently that the American Board of Pediatrics may be rebranding the name a bit, but to date, it still goes by Entrustable Professional Activities. And these EPAs were developed by the pediatric community with guidance by the American Board of Pediatrics. And they are the clinical, professional, and scholarly activities that are deemed necessary for physicians to be able to achieve, to provide safe, effective, evidence-based clinical care, while also advancing their fields through research, education, advocacy, and informing policy. And they're akin or related in some ways to the ACGME, the Accreditation Council for Graduate Medical Education, which has milestones, the subcompetency milestones. And so those are kind of smaller units of practice of what individual physicians need to do for patient care, whereas the EPAs are a little bit more of the overarching umbrella view of activities.
So what did you find when you looked at the EPAs across fellowship and between trainees and fellowship program directors?
So using a measurement tool called the EBA level of supervision scales, which is a spectrum of ability from, being able to, let's say, see a patient only with a, direct supervision to being able to practice without any supervision on the far side of the scale. What clinical competency committees, fellowship program directors, and fellows did was think about their subspecialty specific and subspecialty common pediatric EPAs and see where they fell on that level of supervision scale. And so from spring 2019 to spring 2022, and actually twice a year it was happening that fellowship program directors and CCCs were reporting on these EPAs, but we took the spring data for those years. We said, well, where are second-year fellows falling in these subspecialties? Where are third-year fellows falling in these specialties? And then we basically reported on those level of supervision scale numbers. And what we found is that at the end of 2 years for subspecialists in training, fewer than 50% were meeting a threshold that most fellowship program directors would feel comfortable graduating them, whereas many, many more, nearly all, were reaching that threshold by the end of the 3 years of training. And so that was where the concern came from in this paper, that with the way current training is set up and the current requirements, we're not hitting the mark at 2 years currently with the EPAs.
And do you think that result is built into the nature of fellowship training? Is there a way to hit these marks in 2 years? Or is 3 years just really what it takes?
My professional and only opinion, I'm not speaking for APPD or ABP or any of the other subspecialties, but I do think it can be done if the requirements are changed. And it probably depends on the subspecialty. So I can, again, only speak for adolescent medicine because I know those requirements by heart. And as I said, I have graduated people in 2 years, so I know it can be done. It's not easy. It's busy 2 years when we're trying to pack everything that we think is really important for a fellow to learn in that time. 3 years gives a lot more flexibility to explore areas of our subspecialty, to maybe get a master's degree in public health, which many of our fellows do, which you can't do in 2 years. That third year is often a real leadership year where people are thinking about their research or public health or community work, et cetera, growing their teaching skills. So I do think that third year has a lot of merit. But I think if we're just focusing on clinical skills and getting clinically ready to practice in the community, I think some subspecialties can do that, but I can't speak for all of them because cardiology, hematology, ICU, neonatology, all of them some of them have more procedures, some of them have, a different breadth of care that they have to learn. And so I wouldn't want to be cavalier and say that, yes, absolutely all subspecialties could do it in 2 years if the requirements and the training curriculum was changed.
Well, I think a lot of program directors and trainees are going to read this study. What takeaway would you like to leave them with before they do?
I think the main takeaway is that if people really feel strongly that a reduction in the duration of fellowship is needed to get more people into our fields or just for better patient care, to get more people into becoming faculty and practicing clinicians, then they have to be ready for some unintended consequences, and they have to be ready for fellowship training to change pretty drastically from what it is now, because the way it's currently laid out, we're not hitting the mark for many trainees. Now, some trainees are still hitting the mark, and I also have to think that, if we're going to say everyone has to do it in 2 years, things have to change really drastically. So I think just people have to really think about what they're going to give up if they give up that third year and what the impacts are going to be on the physician scientist pathway, people going into leadership roles, getting graduate degrees, and that may be a significant loss that doesn't result in people going into our fields because they want those things.
Well, Dr. Sarah Pitts, we're glad you're in our field, and thank you so much for joining us today.
It's been a pleasure. Thanks for having me.
To read the paper, many pediatric subspecialty fellows are not ready to graduate from fellowship in 2 years. Visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say David, what's your say this week?
Well, I am really excited because we've talked before about the large Haitian Creole speaking population I serve in Goldsboro. We just recruited a labor and delivery nurse who is a native Creole speaker, and she's going into rooms with me now, and she has absolutely turbocharged my learning because there's a bunch of stuff I've been saying that's like good on Duolingo, but not exactly right at the bedside. So I am so happy to have not only a superb staff member on our unit, but also a personal tutor.
You made me change my say because I want to recognize in our hospital, there is one Mandingo interpreter because we have a lot of Mandingo speaking patients. And this interpreter is just so well loved amongst the staff. Their name is Ben. And just a joy, an absolute joy. And so you cannot celebrate enough a good interpreter who really helps you care for your patients. And so my say is for Ben because he's just an incredible resource for our unit.
I love that. Our job is all about connection and communication, and getting help with that always makes us better. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. We're taking a spring break, but we'll be back in a couple of weeks with the April edition of First Up.
We'll talk to Associate Editor of Digital Media for the Journal Pediatrics, Dr. Rachel Moon. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.